Hello, my name is Rajeev Attam. On behalf of all my co-authors, I wish to thank Endoscopy for this wonderful opportunity to present our work, EUS-guided sutured gastropexy for transgastric ERCP or ESTER in patients with Roux-en-Y gastric bypass, a novel, single-session, minimally invasive approach. With increasing prevalence of obesity, weight loss surgeries are being performed in large numbers, with Roux-en-Y gastric bypass being the most popular option. Patients who undergo weight loss surgery such as Roux-en-Y gastric bypass are at a higher risk of biliary disease. Access to the papilla for purposes of ERCP is technically challenging in patients with Roux-en-Y gastric bypass anatomy due to the partitioned stomach. Current options to access papilla in such patients include deep endoscopy or transgastric ERCP through a gastrostomy. The gastrostomy can be placed by interventional radiology, by surgical means, or by retrograde access of bypass stomach using deep endoscopy. Available techniques are hampered by complications, technical difficulty, or invasiveness. Deep endoscopy using an endoscope or device-assisted endoscopy such as single balloon, double balloon, or Spire's over-tube endoscopy can be time-consuming and technically challenging. It may not be successful in patients with long Roux limbs. Even when papilla is reached, cannulation and other pancreaticobiliary interventions are difficult with a forward-wing scope which lacks an elevator. Previously described techniques of transgastric ERCP through a gastrostomy created by interventional radiology or retrograde access of bypass stomach using deep endoscopy require gastrostomy to mature over a period of 3 to 4 weeks to avoid separation of stomach from anterior abdominal wall while ERCP is performed. This adds an extra procedure, thereby increasing the cost of medical care. Such techniques also exclude patients where ERCP needs to be performed right away without the luxury of waiting for 3 to 4 weeks. While surgery is almost always successful in providing a gastrostomy for transgastric ERCP, it is more invasive. Surgical approach may also not be feasible in some patients with multiple prior surgeries and dense intra-abdominal adhesions. In 2009, our group developed a novel technique of EUS-guided insufflation of gastric remnant for the purposes of G-tube placement for therapeutic endoscopy and ERCP. We subsequently developed a technique of secure gastrostomy by sutured gastropexy using a readily available laparoscopic suture passing needle. By combining the two techniques and creating a secure sutured gastropexy, we are able to perform single-session transgastric ERCP in Roux-en-Y gastric bypass patients. In this technique, EUS scope is advanced to gastric pouch and the bypass stomach is identified across the pouch or the Roux limb. The bypass stomach is now accessed using an FNA needle. A wire is advanced into the bypass stomach under fluoroscopic guidance and multiple wire loops are formed. Now room air is injected through the FNA needle to maximally insufflate the bypass stomach. As the remnant bypass stomach is insufflated, it becomes easily identifiable under fluoroscopy. A distended stomach is an easy target for percutaneous puncture. Percutaneous puncture of the bypass stomach is performed using an 18-gauge needle and 2 018 wires are advanced into the gastric lumen. One of the wires is used as a safety wire while the other wire is used to dilate the needle track. A stone extraction balloon is used over the safety wire to provide counter-traction while the track is serially dilated 20 French. Now a peel-away sheath is inserted to allow passage of a pediatric gastroscope. The pediatric gastroscope is used to perform sutured gastropexy, and the wall of bypass stomach is now secured to anterior abdominal wall. 4 full-thickness sutures are placed to create a secure gastrostomy. Gastrostomy is now further dilated to 15 millimeters and a 45 French laparoscopic trocar inserted to allow passage of a standard duodenoscope. ERCP is performed using the duodenoscope without the fear of breakdown of gastrostomy and separation of stomach wall from anterior abdominal wall. Upon completion of ERCP, a G-tube is placed if access needs to be maintained for future interventions. If future access is not required, G-tube is not placed and the site is stressed. In our study, we have presented data from 10 post Roux-en-Y gastric bypass patients who underwent ESTER between July 2009 and September 2014. Access to the bypass stomach was successful in all 10 patients. A secure gastrostomy using sutured gastropexy was created in 9 of the 10 patients. ERCP was successful in 9 of these 10 patients. In one patient, even though the bypass stomach was accessed by EUS-FNA, percutaneous puncture was unsuccessful due to intervening Roux limb. This patient underwent ERCP through a surgically placed gastrostomy. There were no adverse events related to the technique. ESTER provides for a safe and a minimally invasive approach to perform single-session ERCP in patients with Roux-en-Y gastric bypass anatomy. We believe antegrade access of bypass stomach using EUS followed by sutured gastropexy is an easier and safer approach. It allows for single-session ERCP without having to wait for 3 to 4 weeks. We prefer sutured gastropexy over T-tacs while creating a secure gastrostomy for 2 main reasons. First, 4-quadrant full-thickness sutured gastropexy provides a gastrostomy that prevents separation of gastric wall from anterior abdominal wall as the gastrostomy is dilated. It is more durable than a gastrostomy created using T-tacs. Secondly, a sutured gastropexy does not leave behind any metallic foreign bodies. T-tacs, on the other hand, have been reported to cause problems such as perforation in long run. Our technique is also not without limitations. ESTER may not be suitable in patients with antegastric Roux limbs. Careful examination of the cross-sectional imaging is therefore essential prior to planning such a procedure. ESTER requires close cooperation between a gastroenterologist and a surgeon trained in minimally invasive techniques. It may not be suitable for smaller centers lacking such expertise. We thank you for your attention.